Hello and welcome to the Feeling Good podcast. I am your host, Fabrice, and joining me here in the Murrieta studios is Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. This episode contains some graphic material that may be disturbing to some listeners. Listener discretion is advised. This is episode 45 of the Feeling Good podcast. And
hello, Fabrice.
Oh, hi, David. Tis me. Before we get started on this, I wanted to mention one more time that you're going to be doing two intensives, one in Canada, one in the San Francisco Bay Area. If you could give us the dates.
Yeah, the Canada one will be in Banff, which is a kind of a vacation spot, apparently quite popular in Canada. It'll be July 17th through 20th.
2017, that is.
Yeah, that's right, 2017. And if you're interested, it's a great 4-day training for mental health professionals in the treatment of depression and all the anxiety disorders using the new team CBT. And you can call Jack Hirose and Associates. He sponsors all of my Canadian workshops, and he's at 1-800-456-5424.
And of course, all this information is on your website,
feelinggood.com.
So
on the workshop page, then they can link to the brochure and to the
I imagine people who are listening to this while they're jogging or driving are not going to stop and pull out a notebook to write down the information.
Right. So you can find it there on the website. And then the California one, which will be near San Francisco in Burlingame, will be July 31st to August 3rd.
2017.
Yeah, 2017. And you can call the sponsors for more information, 800-258-8411. That's 800-258-8411. And the intensives, the seating is limited, unlike my usual workshops, and they frequently sell out. And so if you're interested, it wouldn't hurt to...
because it's coming up soon.
Yeah, they're coming up soon, and give them a call so make sure they'll hold a spot for you.
Yeah. One thing I would like to add also is that we've been getting quite a few subscribers to the podcast. It's getting quite popular. In fact, we've had some very positive comments on the live session we did with Mark a few weeks ago. And I wanted to let people know that there'll be more live sessions coming up. We're going to be taping one pretty soon. And we have also a recording of an intensive you did with one of the participants, and
live session in Philadelphia,
and
it was really blow away. She was a wonderful woman to work with. She was been in pain again for almost 10 years because she felt that her husband's death was her fault, and it's fantastic.
Yeah, so stay tuned for that. We're going to be working on editing these podcasts. So,
and producing them for you.
And producing them, editing, producing, and publishing, and so on. We're getting better at this.
Yeah. Do you want to read the letters on the live podcasts?
So,
have them? I think they were from Danny.
Well, what we have
over there. This one here.
Somebody wrote a question about OCD. Since
okay.
We're doing OCD right now.
Okay, fantastic. Yeah.
And this is Rajesh, who says that if someone with OCD traits brings down his compulsive ritual or cures it, can this type of anxiety manifest itself in other forms, like obsessively worrying, or maybe even through generalized anxiety disorder because of the organic nature of the OCD problem?
Well, the answer is yes and no. That definitely will happen, but we don't know the cause of OCD or any psychiatric disorder. We don't know to what extent it might have biological causes. due to the structure of brain tissue versus psychological causes, the so-called wiring, the so-called learning. But regardless, this problem is if you don't use the hidden emotion phenomenon with any anxiety disorder, including OCD, then once you extinguish the symptoms, they'll flare up again in some other format. And we've had several podcasts on the hidden emotion technique, but the idea behind it, and we're going to go in another direction today with OCD, but that primarily the people who develop anxiety disorders are very nice people. And if you're listening to this podcast and you've struggled with shyness or social anxiety or performance anxiety or phobias or OCD or any form of anxiety, the odds are overwhelming. You're this exceptionally nice person. And what that means from a practical point of view is that some of us seem kind of programmed that when we have certain forbidden emotions, and a common one is anger, but it's not always anger, instead of dealing with the conflict with somebody, we kind of sweep it under the rug, and then it can come out indirectly in the form of any type of anxiety, or even in many cases as chronic pain or headache or belly pain or fatigue or dizziness. And if you make the individual aware that they're doing this and show them how to bring those suppressed or repressed conflicts to conscious awareness and deal with them, then the anxiety will definitely improve or usually disappear entirely at that moment. And this component is missing from almost all of the current treatment protocols for OCD that are focused on cognitive behavioral kinds of techniques, which are valuable, and we'll go into some of those today. But they are limited. You need to come in from 4 different dimensions when you're treating anxiety, including OCD, and we've talked about in previous podcasts
we've gone over that.
The hidden emotion model, the cognitive model, the exposure model, and the motivational model. And today we'll be focusing a little bit on the exposure model. And you had asked me when we were first conceptualizing doing these podcasts that I've got these 50 or 75 techniques I've developed, and our original plan for the podcast was to bring one of those to life in each podcast. I remember we were eating lunch or something, and I think downtown Los Altos at that Vietnamese place. La Tour Eiffel was the name of the restaurant.
Yes, La Tour Eiffel.
And in fact, you had a crepe.
Well, good memory.
But you didn't like it. but at any rate, you were saying like we could do cognitive flooding. Like how does that one work? And so today we're going to talk a little bit how you can use cognitive flooding in the treatment of OCD, although it has value in all of the anxiety disorders.
Yeah. So let's talk about this. And now. We've talked about flooding before in terms of exposure. How is cognitive flooding different?
Sometimes what the person is afraid of, they can't confront in reality. Like, let's say someone has a blood and needle phobia. You can confront that in reality using gradual exposure type of thing. Say, first you would just hold a needle without going to the actual place where the blood is drawn and just hold it until your anxiety goes away. And then you do something more threatening and more threatening and more threatening until finally you can have your blood drawn without passing out or getting anxious. But sometimes, or you could do it all at once, and just flood yourself with anxiety. But sometimes the things that we're afraid of are things that you can't confront in reality because they don't exist in reality. It's some fantasy in your mind that's terrifying to you. And I'll give a dramatic example of that. I was, and I'll disguise the identity here, but I was asked by a psychodynamic therapist, which is unusual, to collaborate in the treatment of a woman who looked like she had significant OCD, and she was pregnant, and let's say she was from San Diego and was an executive in a software company and was doing well, had a great marriage, everything in her life was fine, but she started obsessing that when her baby was born, this was her first pregnancy, that somehow the babies would be switched at the hospital, and she'd end up with the wrong baby. And he had tried a number of things, like psychodynamic therapists might think, well, maybe she doesn't want the baby or something like that, or some kind of theory to explain why she's so upset about this.
Some hidden emotion, perhaps.
Yeah, a hidden emotion thing, and that didn't work. And so he said, well, could you try, some of your cognitive techniques? And so I worked with her. She was very pleasant, very, very motivated, did all of her psychotherapy homework. And I tried about, 20 of my techniques, like examine the evidence and, identify the distortions in this thought that, I'm going to end up with the wrong baby, was the thought that was kept bugging her. And she tried and tried, and she was pleasant to work with. She gave me perfect empathy scores, and I couldn't make a dent in this severe anxiety about getting the wrong baby. And so then finally the time came and she delivered the baby, and it was a cesarean section. And the doctor told her, before she saw the baby, that said, you have a very healthy baby boy. During the surgery, I inadvertently cut his heel. But it's not severe. We sewed the cut back up, and it won't do any damage. It might not even show, but that way you'll know this is your baby, because he knew she was really worried she'd end up with the wrong baby. So he presented her with her baby, and she very anxiously looked at the foot and saw that there was the surgical work there, and the cutting sewed up this cut, and she was relieved. Oh, this must be my baby. And her OCD went away for a couple of hours, and then she started thinking, but maybe this cut is on the wrong angle, and because I thought he said it was a different angle, and maybe I have another baby with a cut on his foot. And then they discharged her, and she went home. And this is just very typical OCD. And so her obsession is, I might have the wrong baby, and her compulsion was to go and check him 50 times a day, to look at stare at his heel and try to figure out, is this my baby? And I continued to use another 10 or 15, cognitive therapy techniques, all to no avail. And she wasn't that happy either, because she was obsessing, she was depressed and so anxious, maybe I have the wrong baby. Well, listeners might recall a previous podcast on the what-if technique. I gave an example. Yeah,
that was not too long ago.
Yeah, a woman with agoraphobia. And so finally I decided to use the what-if technique. I hadn't done that one. When you do the what-if technique, you find out what is the person the most afraid of, what's the core feared fantasy, and then you have them confront their fear with exposure.
Sure.
And so I said to her, well, I'll call her, say, Lillian. Lillian, let's imagine, just for the purpose of argument, that this is not your baby, that you have the wrong baby. What would that mean to you? Why would that be upsetting to you? That's the what-if technique. Mm-hmm. And then whatever she says, the therapist says, write that down.
There's a downward arrow.
Yeah, the downward arrow. And then what if that happened? What are you the most afraid of? So she said, well, if this isn't my baby, then that means some other people have my baby. So I said, okay, write that down and put a downward arrow under it. And what if that were the case? What would you be the most afraid of? What's the worst that could happen? And she said, well, maybe some bad people have my baby. And then I thought, well, okay, write that down and then put a downward arrow under it. And suppose that were true, what are you the most afraid of? What's the worst that could happen? And she said, well, they might smuggle him down into Mexico. So I said, well, write that down and put a downward arrow. And what then? What are you afraid of? And she said, well, they might take him into a cabin in the middle of the desert. I said, okay, well, write that down. And then I started to get kind of a little uncomfortable with it because it seemed to be heading in a kind of a dark direction. but I said, I've got to stick with the procedure here, and then what are you the most afraid of? And then she said, well, maybe they're going to torture him. And I said, write that down.
Wow.
And then I thought, my gosh, now I'm supposed to do exposure. And this sounds so creepy. Right. And
you don't want to go torture a baby, right?
Yeah. But I said, now Lillian, that's kind of a horrible thought. And according to my training, and I can't force you to do this, but I think then what you need to do is confront that fear. And we can use cognitive exposure, cognitive flooding. I can have you fantasize that and make yourself as anxious as possible. And if it was too repulsive for you, then, I wouldn't push it because it seems so grotesque. But we've tried every other technique, and it's my hunch that we should do this. Well, she was a good egg, and she said, okay, I'll try it. And I said, now close your eyes and imagine them torturing him. And what do you see in your mind's eye? And she came up with these horrible things. It was just terrifying and disgusting. And she said, oh, they keep him in a closet without food or water. And then they take him out and they...
Let me interrupt you, but just to make it clear to listeners, what you're doing here is imaginary work that cannot be done in reality.
Yeah, that's why you use cognitive flooding.
Cognitive, right?
Because the thing she's afraid of doesn't exist in reality. She can't go out and confront it, but she can confront it in her mind's eye. And if it's anxiety-provoking to her, then the odds are overwhelming that it will be beneficial for her. But so she says they're swinging, they grab him by the foot and they're swinging him around through the air and they bash his head against the closet door and his brains go splattering. And now they kick him down the stairs, and then they take him outside and they use him to play soccer with, and they throw him onto cacti, and just
probably needed to have a warning on this podcast.
Maybe we should. And as a therapist, when you're working with cognitive flooding, I think the really fine therapists who are experts in this area recommend this. This is what you need to do, no matter how gross or bizarre the fantasies are. But many therapists will not go there.
Yeah.
Because and I was telling myself, I don't know if this is good therapy or malpractice. But by the end of the session, she was still 100% anxious and grossed out, and I was too, and she hadn't improved at all. And I said, now Lillian, I'm going to tell you, I want you to keep doing this for 20 minutes a day for homework, and if you don't want to do it again, I can't push you to do something as awful as this seems to be. But I believe we need more time. I can't tell you how many minutes it will take before your anxiety breaks, but I know we need more time. Well, she agreed to it, but came back the next week not having done her homework. And that was unusual because she was very motivated and cooperative, but she said, I'll do another hour of it here in the office. And so we did another hour of this horrible cognitive flooding. And again, at the end of the session, she'd had no improvement, still 100% anxious and panicky and grossed out. And I said, now I really need you to help me on this, and if you would, and just do 20, if you can just put up with it for 20 minutes a day, and then record, how anxious you are every minute or two, and write down what the gross fantasies are, and then. She agreed to it, and she came back the next week, and she handed me the depression and anxiety test at the beginning of the session, as she always did, and her symptoms had completely disappeared. And she said she was just in a state of joy and jubilation. And she said that the first time that she had done this at home, she still got 100% anxious.
Yeah.
The second day when she did it, she said she could only get the anxiety up to 50. And an important tip for therapists and perhaps for patients is the goal is not to lower the anxiety, but to keep it as high as you can for as long as you can. And she said the second day it lost some of its credibility it didn't seem that real. And then the third day, she said she couldn't even get it up to 1%, and the fantasies just seemed totally ludicrous.
Yeah.
And she said she suddenly realized this was her boy, her baby, and all the love that she had came pouring out, and the joy of being a mother. And she was said she was ready to to terminate the therapy, that she'd been completely cured. And so that's cognitive flooding, and again, it's just one of many techniques I use in the treatment of anxiety disorders. And there's probably some teaching points here that my good colleague Fabrice will now point out, I hope.
Well, interestingly, we've been talking about OCD for the past 3 podcasts, but OCD, at least in your model, seemed to be just one variation on anxiety disorders, which is kind of drifting away from the DSM-5 in some ways. You seem to lump those under the same.
Well, under DSM-5 now they've changed it, and they lump OCD with body dysmorphic disorder as a kind of an obsessive compulsive kind of category, which is fine too, to categorize them that way. But it used to be thought of as an anxiety disorder, and it certainly is a severe form of anxiety. And again, we don't know the cause, but I think it's great that we, at least in my experience, we've got powerful and very effective treatment techniques for OCD. Some people think that OCD is some, long-term thing with a poor prognosis, and they throw a lot of medications at OCD patients. But in my experience, OCD is generally pretty easy to treat without medications. And my goal in treating OCD is a pretty rapid and total elimination of symptoms, not partial improvement.
And do you have any sense of what the curative element is? Why does exposure work? Because people get exposed to anxiety-provoking things all the time, and that doesn't necessarily cure them. So
yeah, and I thought of another quick vignette too, Coca-Cola vignettes, which is some teaching points. But yes, well, I think that there's a learning dimension there. You see, if you run away from your fears, now I'm just talking about exposure,
right?
But then you continue to believe that thing is very dangerous. And it's so painful to confront the fear that you keep running away. And then when you run away, the fear intensifies. And I can tell that from personal experience, because I've had myself so many forms of anxiety and phobia. So when I talk, I'm talking from the heart, and I know how to beat these things from personal experience. But once you confront the monster, you discover that the monster has no teeth. The thing that you're afraid of really wasn't dangerous. And that provide that, and then when you discover that the thought really isn't true, the thing I was afraid of really is not dangerous. It creates a kind of euphoria or enlightenment.
Yeah.
Go ahead.
Well, I have a slightly different twist on OCD.
That could be.
I'm thinking of one patient who. He doesn't have any particular fear, but he has racing thoughts. Like he could be watching a game, and then he would start adding the score. He doesn't need to do that. The TV people will do that for him. But he keeps adding the score. Then he keeps checking his addition to what they're showing on TV, and then he's wondering whether that player did the same score in the previous game, and he goes into this. Immense chain of thoughts.
Sure. Well, see, that's the compulsive ritual, and you need to treat that with response prevention, which is just simply telling the patient, I'm going to command you to stop doing that. If you want me to treat you, you must agree to stop doing that. And then you have to explain to the patient when they give up that ritual. Like I had a woman, every time she'd drive across past a Catholic church, she'd have to recite certain things in her head, some elaborate thing, or she'll be condemned to death by God, or, something like that. And I don't remember what her ritual was, but I just said, if you want me to treat you, you're going to have to stop doing that. The same with your patient. And then you tell the patient, this is like withdrawal from a drug, because you do all those rituals and checking to make yourself feel more relaxed. So, say with this woman, I didn't think of it, but I should have told her, you're not allowed to check his foot anymore. That would be response prevention.
Yeah.
And then you'll get more anxious. But if you just stick with that anxiety and don't give in to the compulsion will disappear generally in 2 or 3 days. You'll still have the obsessive fear, and that's where you have to use cognitive exposure and other techniques, and also the hidden emotion technique, because I can tell you, a dollar against a dime, that your patient who does all this counting on baseball games, there's probably things he's bothered by in his life, his marriage, his job. There's something bugging him that he's sweeping under the rug. And that probably would provide the hidden emotion model, another treatment handle there. But I wanted to mention that another good teaching point with this patient is, you can see why 80% or 75% of the therapists in America won't use exposure in the treatment of anxiety. Because the therapist is frightened, thinking, oh, this is too extreme, and if the therapist gives in to that, then the treatment is doomed.
Yeah,
I can give you an example. One more quick example of this. I had a student who blossomed into a very superb psychiatrist, but we received a referral of a man who had this intense fear of drinking Coca-Cola. And
okay,
and
just don't do it.
Well, that was his solution, but that was the wrong solution, because he was afraid that if he got caffeine into himself, that he'd go crazy.
Mm-hmm.
And he was very, very controlling, and he'd been referred by a high-powered, well-known OCD specialist to my colleague, but he had overpowered everyone who treated him. And so I watched my colleague, had the opportunity to watch him treat this fellow.
Yeah.
And they were kind of arguing about whether or not the fellow should drink 1 ounce of Coca-Cola.
Yeah.
Or maybe a tablespoon of Coca-Cola,
yeah,
type of thing. And the patient overwhelmed the psychiatrist who gave in. And
how did he overwhelm him?
Oh, it's just that, oh, no, I can't drink that. That's too severe. I'm going to go crazy. Oh, no, I'm not ready for that. Anything but this.
Mm-hmm.
And the psychiatrist gave in. And I said to myself, he's doomed. This patient is doomed. The psychiatrist was afraid to use the gentle ultimatum and the sitting with open hands. And if it had been my patient, I would have said, well, look.
Which we can remind people what that is.
Yeah, well, the gentle ultimatum is, if you want me to treat you, you must do this.
Yeah.
It's not negotiable.
Yeah.
And if you don't want to, drink the Coca-Cola, then I'm not the therapist you're looking for. And just decide it right now. If the patient wants to drop out of therapy, they're on their way. At the same time, you use the dangling the carrot. And say, on the other hand, if you're willing to do it, I have no doubt that we can beat the OCD together. But there will be a price to pay, and I'm asking you to pay it now. And then the therapist has to stick to your guns. But my colleague refused to do that. And then I heard 2 years later he was still struggling with the patient who had shown no improvement. The patient eventually dropped out of therapy. And it's so sad, because recovery was just minutes away.
Yeah, it was, yeah.
So anyway, that's a teaching point. But you see, it's sometimes hard, and therapists get hypnotized by patients. And my gosh, I was very frightened. But if I hadn't had a great relationship with this woman, who was afraid she had the wrong baby, I might have backed out too, and then she would have been doomed. So you've really got to stick to your guns and kind of have some faith as a therapist that the exposure is going to be really mandatory.
Well, this brings up a good point, because you will often hear therapists say that, especially when they're dealing with somebody who has some anxiety due to trauma, saying that, well, if you bring up the trauma too hard or too soon or in a way that's too intense, it will re-traumatize the patient.
Well, I just say I've been doing trauma workshops, and I've treated 50 severe trauma patients in the last 2 or 3 years, and every one of them I've seen a complete elimination of symptoms in a single session, and I've never seen this re-traumatization. But I think what happens, you see, when I'm working with patients, I don't go into any techniques until I'm getting a perfect empathy score first. Yeah. There's got to be that warmth and trust, and then you have to have a therapeutic agenda and melt away the patient's resistance and make sure the patient is on board for doing this with you. But most therapists don't know how to melt away therapeutic resistance, so they kind of impose these techniques on patients who are reluctant, and then the patient punishes the therapist by freaking out when they do the memory rescripting or the going into the past or the visual imaging or whatever form of exposure. But I've just never had those problems, and I've had almost 40,000 therapy sessions with severely anxious and severely depressed individuals, and I've never once run into that. But it's always something to you always want to be cautious. That's for sure.
That's right. Well, thank you so much. So I think that pretty much covers our foray into OCD, and we'll see what our next podcast has in store for us.
Should we do relapse prevention training?
Well, maybe we will. We'll see.
Okay.
We'll see that next week.
All right. Okay. Thanks, Fabrice. It's always fun.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. Theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.